It is correct to say that I'm not here to talk about official policy, but having said that, these slides I'm using have been prepared by the agency, New South Wales Health, and in fact, as you will see, and spend a moment on the actual title slide, it'll give you a couple of clues. They weren't prepared for me. They were prepared for Richard Matthews, and they're prepared for his introduction to the first meeting of the new Program Council. Now, I'll put that into context in a moment, but it's important to acknowledge that and put it into context. The other thing worth noting, and this wasn't, as I said, prepared for this forum, is the title and the language. It talks about a vision for children and youth, or young people, and that shows up in much of the current literature and strategy documents. And the second line is also important because it's the New South Wales Health Children and Young People's Health Program Council. Now, that hasn't been around that long. Most of my career, people have been talking about children's health, child health, and paediatrics as the common catchphrases. Recent language tends to very frequently encompass youth health, and presumably in this audience, that's a good thing. I mean, I would have thought that that's an achievement you can take some credit for, that these days people generally think more broadly and the language has shifted accordingly. The presentation that I'll be talking to, that was prepared for Richard, encompasses these major subjects and also makes some reference to the COAG reforms that Solange has already covered, but I'll put it into particular context. Now, a few words about the Garling Commission and report. It's interesting to note that the precipitant to the whole process of that commission was actually an adverse event in a person described as a young person in the context of this conversation, Vanessa Anderson, who died after a golf ball injury. And that, along with other things, precipitated a very major review of the New South Wales health system, undertaken by Peter Garling SC. Took most of 2008 to conduct it. It was quite a massive exercise, and if you see the report, I presume some or all of you may have seen the report, it is a huge document, and its content is amazing when you think about how thoroughly it interrogates the health system and how many proposals it makes. It's about 140 odd recommendations, which are actually many more than that once you consider the subdivisions in each of those items. But in that work, he took a particular interest in children's and youth health, developed a passion for it, I would say. Only 3 recommendations out of 139 are specific to it. That's 9, 10, and 11 as quoted on that slide, but fairly important and radical recommendations. So he wanted to create a statewide authority specific to this purpose, to cover all aspects of children's health, or read children and youth health, and a couple of other expectations doing strategic planning and considering a new tertiary facility for the state. But it was probably too much to swallow in terms of an authority that was so discrete, because it probably could have led to potentially other aspects of fragmentation. So it wasn't accepted in that detailed context, but it was accepted in principle. So now we're up to March 2009, when the government issued its formal response to the inquiry, and it labelled it under the banner or brand of Caring Together. Lots of things were put into effect immediately, but this bit about New South Wales Kids, which became the brand name for all the things I've been talking about, was seen as something that'll take longer. So a transition governance group was established, and several more steps were undertaken over time to try and deal with this. And what eventually was agreed to was not nearly as specific as the original Garling recommendations, but nevertheless it was a major and fairly radical change in the way we do business. And you can see the dates there. Early this year, January, there was the sort of discussion paper after lots of prior consultation, which attracted more feedback. Then a decision was announced in May, but not actually implemented till mid-September, so it's all quite recent. Now, before I go to that one, let me just pause for a moment and talk about why this is a good idea. The things that have troubled us historically have been a couple of major things. I could talk about lots of it, but two headline things. One is the fragmented way we think about health and well-being, and then you think beyond health as well. The way it's delivered in Australia, and that's addressed, at least partly by COAG, attempted to be addressed, but lots of other aspects of New South Wales specific issues that were highly fragmented. And one would hope that this will deliver a more cohesive approach. Secondly, the priority given to children and youth has always been somewhat marginalised by the pressures of the ageing population and some of the immediate priorities that creates, and clearly the benefits of long-term investment in children and youth is paramount. But if you're dealing with day-to-day survival in a health facility, I'm talking about a manager of a health facility, the pressures are going to be the here and now, which is very much dominated by chronic illness in the ageing population. So for all those reasons, the capacity to identify, map, quarantine, protect, and potentially grow the emphasis on children and youth health was considered to be a good thing. There's an operational component to the process, and this is a bit about the Sydney-based children's hospitals at Randwick and Westmead, and that's already been operationalised in the sense that there's a single chief executive across the two sites. Now, Solange made reference to the progression of the local health networks. This one's already established as such, so it already has an advisory council, a chair and a chief executive, and it's a functional rather than geographic network across Sydney. The John Hunter Children's Hospital has stayed somewhat different within its own current area health service, which interestingly will remain as an LHN, albeit quite massive in size. Now, within the Department of Health, there is, or will very soon be, a child and youth branch. Again, note the language. It'll include a few other things that aren't strictly child and youth. And other things will stay where they are. The appointments, my own appointment is mentioned there. This is Richard's slides, not mine. That was one of the undertakings, that there would be an appointment of a chief paediatrician and also other key support advice from people who are expert in community child health and child protection respectively. The establishment of the Program Council, and this is what I referred to in my title slide, was a key component of creating an umbrella group to guide this whole process. And the first meeting of that took place a couple of weeks ago, and that's where these slides were presented by Richard. In addition to which, there's an advisory committee to Director General and Minister. That's essentially a reshaping of the Health Priority Task Force that existed previously, on which key players here were represented. Now, I won't dwell on the structures, except that they correctly used child and youth as the name for the branch, which is there. But the rest is really a bureaucratic map. In terms of how it's going, lots of consultations have occurred, the structures have been defined, appointments have been made, and the branch, establishment of a branch and an umbrella group to bring the various other components together is ongoing. It's worth mentioning that when I described the Program Council, that's a statewide entity which encompasses all the bits of the health system. Within the department, there's also a need for more cohesion, because the branch, albeit key to the process, is not the exclusive implementation arm of child and youth policy. I mean, there's bits like mental health, there's statewide services, which is about hospital program and policy development, hospital-based. There's population health. All of these live in different bits of the department. So albeit the branch is going to be critical, but the branch has to work with the others. So there's also a structure required to bring them together within the department and then work with the broader Program Council. Plenty of challenges. And in fact, that's what this slide is partly focusing on. What's ahead? Well, there's clearly a focus on the universal components of healthcare provision. And this is a philosophical view, which I wholeheartedly support. And then recognising from that, two things. Firstly, vulnerable populations that need additional aspects of the universal component. But there's also then subgroups that require escalation of care for various reasons, whether it's for child protection reasons, health development, education and development reasons, or, of course, the thing everyone knows about is the hospital sector, or people who get sick and need other bits of care to do with their illness. But that's the construct. And of course, here this is where the local health networks show up, and this is a reference to the earlier presentation. What we now plan to do will have to incorporate the new structures you've talked about, and I'll come back in a moment to tell you why that's a bit of a spanner in the works, but nevertheless needs to be worked on. And there's a lot of planning and target identification and measurement to be done as well. I won't dwell on the next 2 or 3 slides because they're about early childhood, which is not the purpose of this session. It's worth, however, noting that there's a sequence of planning processes that will be undertaken as part of the New South Wales Kids overall strategy. Now, this is the sort of link between this and the previous presentation. The COAG reforms came along in parallel with this, and one could argue we are somewhat overdone with reform. As a consequence of which the local health networks and the PHCOs or Medicare locals are coming into existence, and all the funding structures that we just heard about. The impact that it has in terms of our capacity to deliver on the New South Wales Kids strategy is that we have very much a statewide cohesive approach to this, which is, I think, critical to it. There's a question to what extent the new entities are disruptive of that, because there's a move towards local autonomy to an extent. And it's possible, as Lange said, that with a change of government, the emphasis on local control will heighten rather than decrease, because that's part of the opposition's current policy as stated, that they believe strongly in local engagement, local control of health services. Whereas, while that has importance, we are very concerned about the capacity to be cohesive across the whole state. As part of that, the appointment of directors of children and young people's health in each of the current area health services has been an objective of the reform, and it's kind of temporarily been put in place. They've been nominated and they've participated in the first meeting of the Program Council, but everyone knows this is a very transitional reality. How will that work in the new entities? Will they be in the clusters? Will they be in the LHNs? What kind of seniority will they have if you have to now find potentially 15 or 17 of them? There are unanswered questions about how that will change our approach. So there is a bit of a spanner in the works with the COAG reforms. And again, this is a very brief summary of what has been a much larger presentation a minute ago, but relevant to what's happening within New South Wales Health. Richard chairs or oversees the Transition Office, which is a sort of central coordinating agency within the department. We've heard about the agreements and about the planning of when the LHNs and the payments are due to commence. So this is actually absorbing a lot of people's attention, and it's another detractor from some of the agenda we're pursuing here.